Welcome to another episode of Discovering New Horizons for America. I'm Dr. Jim Polakof, and as my listeners know, each podcast is designed to enhance your health, well-being, and at times, perhaps even stimulate your interest in the welfare of others. If, by the way, you happen to be snoring excessively, or perhaps you have problems sleeping at night, or you might even be sleep deprived, you definitely want to hear this episode. As the saying goes, health is wealth. And my hope is that you will prosper from the knowledge and wisdom of this episode's guest. When it comes to our ears, nose, and throat, many ignore or often dismiss symptoms until they become unbearable. That's when you realize you should have seen an otolaryngologist, often referred to as an ENT doctor. Dr. Waldemar Riefkohl practices at Pinehurst Surgical Clinic and is highly qualified in this specialty. He is certified by the American Board of Otolaryngology and a member of the prestigious American College of Surgeons. A warm welcome to Live Healthy Longer, Dr. Riefkohl.
Thank you, Dr. Polakof. I'm glad to be here.
Well, I'm glad you're here. So anyway, let's get right to a topic that I alluded to in my introduction, namely sleep deprivation, and in particular snoring. So it's estimated, at least a study that I looked at, that some 90 million Americans have a snoring issue, and about 1/3 of these people have sleep apnea. In fact, estimates reveal that 80 to 90% of sleep apnea cases may actually go undiagnosed. So Dr. Riefkohl, tell us about what sleep apnea is, its dangers, and what are the signs of the condition?
Sleep apnea is a condition that can divide it into two separate entities. The first one is called obstructive sleep apnea, and the second one is central sleep apnea. And they're both a disorder in which a patient, when they sleep at night, they're not able to breathe properly. Their breathing ceases. In the first obstructive sleep apnea, the first type, there is obstruction of the airway, oftentimes due to either large tonsils, large adenoids, turbinates that are too big, or deviated septum in the nose. But it can also be due to increase in weight. So as the population has the BMI has increased over time, sleep apnea has become more prevalent.
Is the individual aware that this is happening to them?
The individual may not be aware, but the symptoms include snoring, which the individual may not be aware, but a partner may,
right,
that lives in the home may notice that they're snoring significantly.
Perhaps even in the next room.
That's correct. And the patient may not be aware that they're having sleep apnea, but they may have symptoms where they're not feeling rested when they wake up in the morning. They may sleep at night and feel that they're very restless. So they may be waking up several times during the night for unknown reasons. And patients can oftentimes feel pretty sleepy and tired during the day, even to the point where they feel like they have to take naps in order to be able to get through a good, productive day. So those would be some of the symptoms that a patient may have that may trigger them, or they may want to consider talking to someone like me about sleep apnea and get tested for it.
So let's talk about that, because someone comes to you, perhaps their spouse is encouraging them, and they say, Dr. Riefkohl, I've been snoring excessively, et cetera, et cetera. So how do you actually end up diagnosing whether or not they truly have sleep apnea?
That's a great question. Diagnosing sleep apnea requires a sleep study, also known as a polysomnogram. And that is traditionally that is done in a sleep center in which you come in overnight and they have a little room that looks like a hotel room with a bed and a TV, and they have you lie down and they place several electrodes and monitors for oxygen level, for respirations, for snoring, and they have you fall asleep while you have a sleep tech monitoring you at night. The sleep study is able to tell whether you're having these episodes of breathing cessation. And it can differentiate a patient having obstructive sleep apnea from central sleep apnea. And the reason that's important is because they're not always treated the same. There are different treatments for each one of those, and they have different implications.
So what happens during the sleep study? I've met a couple of people who've gone through it. A couple of them successfully, but one said they couldn't fall asleep. And then what do? Are you you paint yourself in a corner?
Well, some patients don't enjoy sleeping outside of their own home in their own bed, and these sleep centers are always the most comfortable place in terms of the furnishing, the bed, and things like that. Sometimes we'll help a patient by giving them a sleeping medication that they can take about an hour before they actually fall asleep. But we try to avoid that. It can make sleep apnea seem worse than it really is. The other option is doing what's called a home sleep test. Now, a home sleep test is not as good of a test as an in-lab test, but in the majority of patients, it could give us the right information that we need to be able to tell if a patient has the diagnosis or not.
So what happens? You find a patient, you clearly diagnose them with sleep apnea. How do you treat it?
The treatment is going to be based on the sleep study itself. So once I have the results from the sleep study, if the patient has obstructive sleep apnea, it is divided into mild, moderate, and severe. Mild sleep apnea can be treated one of three ways. You can have an oral appliance, which is fashioned by a dentist. The oral appliance is used to move the jaw forward so that the airway is more open. The second treatment is positive airway pressure, commonly known as CPAP or BiPAP, in which you use a mask and a machine at night to provide air under some pressure and resolve the obstruction that happens when you're breathing. And the third is surgery. Now, surgery for mild sleep apnea can involve repairing the inside of the nose if the patient has a lot of nasal obstruction or congestion from anatomic problems. It can also be due to tonsils being too large or adenoids being too large. So sometimes, particularly in children, we'll remove those tissues to allow the airway to be more open.
So does that mean you mentioned mild, medium, or high, so to speak?
Correct.
Is this all from mild, or basically
those are the options for? Yeah, those are the options for mild.
Oh my goodness!
When you talk about moderate or severe sleep apnea, the majority of those patients are treated with positive airway pressure. An oral appliance is less likely to resolve moderate to severe sleep apnea, and surgery is less likely to resolve it, except for one particular patient, and that is the one patient who is unable to tolerate positive airway pressure. So if you have a patient with let's say an AHI of 50, that number signifies the number of times they stop breathing in 1 hour of sleep. 50 times in an hour is considered severe. In fact, anything above 30 is considered severe. So that patient will go through a sleep study with a mask and a machine to determine how much pressure they need to resolve their sleep apnea. Now, I'd say probably about 80 to 85% of patients are able to tolerate CPAP or positive airway pressure, but that leaves about 10 to 15% of patients who are unable to tolerate it. In those patients, then we consider surgical treatment to either open up their airway or more recently, something called Inspire surgery.
Inspire surgery, what's that about?
Inspire is a newer system that I've been implanting in patients now for over 2 years. And it is a device that looks a little bit like a pacemaker device. It requires surgery to place an electrode in the hypoglossal nerve in the neck and to place a little pacemaker device in the chest area. And the way the device works is the respiratory electrode is able to sense when you're going to take a breath. It sends the information to the pacemaker computer that is able to coordinate opening your airway through the hypoglossal nerve every time you take a breath. So it's a coordinated effort to open the airway, bring your tongue forward without having to use a mask or without having to do any other upper airway surgery.
Well, actually, that sounds like a better option. But the pacemaker that you've talked about, obviously, one is implanted in your neck, one device, and then the pacemaker, I'm assuming, in your chest. But that doesn't affect your heart condition or anything of that nature. It's not the same thing, is it?
It does not. It is not the same thing. And we oftentimes implant this on the right side of the chest in the event that the patient, as they get older, or if they have any cardiac issues, that they will require an actual pacemaker, that would be placed on the left side by a cardiologist.
I know this seems much simpler than having to wear the masks and all of the paraphernalia that one has to go if they even have mild sleep apnea. It obviously is a case where, and I encourage our listeners, if you have a snoring problem, you really do need to see your otolaryngologist. Am I correct?
That is correct.
That is the specialty that treats this. That's your specialty, of course. So we're talking about airway problems. So let's go, if we might, from abnormal snoring to various causes of sneezing. It was once believed, and correct me if I'm wrong, but it was once believed that the actual allergy season, as we know it, is typically spring. But many of the 50 million Americans who suffer from allergy are aware it can be a year-round battle. So can you tell us, Dr. Riefkohl, about allergies, how you determine the type of allergy, and what treatment is required for that specific allergy?
So respiratory allergies, as they're commonly called allergies by society, has to do with a body's incorrect reaction to a substrate in the environment, typically something that we breathe. It was very commonly thought that most allergy problems, as you mentioned, are in the spring, but in fact, this pollen from the trees is the only thing that really causes exposure during the spring. During the summer is when the grasses bloom, and some patients can have respiratory allergy from the grasses themselves. And in the fall, we have the weeds like ragweed, and those, when they bloom in the fall, if patients are allergic to those, they can have symptoms during the fall. Winter tends to be the best time for most patients with allergies, but if you have allergies, for example, to dust, oftentimes during those periods of time, you're going into your attic or your basement and pulling out Thanksgiving decorations or Christmas decorations and Christmas trees. We're pulling out sweaters from our closets and our drawers that have been sitting around all year long waiting to be used again. And oftentimes those patients can experience allergy symptoms because of the dust itself.
Speaking of the dust, do you recommend, as an otolaryngologist, do you recommend that people have their ducts cleaned to get rid of as much dust as they can? Or does that have anything to do with the allergies during winter?
Not so much getting their ducts clean. If they have significant dust allergies, then some of the things we recommend are making sure that they change their comforter and their sheets and pillows, covers, at least once a week, and wash them with hot water to destroy the dust mite. It is actually a dust mite that causes the allergen, not so much the dust itself. It's important.
And not just the sheets, but the covers as well.
The covers as well. Yeah.
Interesting.
And then placing allergy covers on the pillows and mattresses, because the pillows and the mattress can accumulate dust particles and dust mites over the years. Most individuals aren't getting a new mattress or new pillows, every year. Oftentimes, most of us have mattresses that we've had for several years, and sometimes they're even handed down from family, from parents to children as they go away for college. And so those materials accumulate a lot of dust particles over the years. So getting an allergy cover for those can limit the exposure when you're sleeping at night.
With obviously these various seasons and different types of allergies, how do you determine if a patient has an allergy, and if so, what type of allergy they have? Can we start there and then, of course, discuss the treatment?
So allergies are diagnosed through an allergy test, and that can be done in two different ways. One is a skin test, in which we provide the allergen to your skin and see if the skin reacts by swelling and causing itchiness. That's the most accurate and effective way of doing an allergy test. The second way is doing a blood test. And the blood test is done to measure levels of IgE. IgE is the protein that is overexpressed in your body when you have an allergy. So, for example, if you have allergy to dust, your levels for IgE for dust are elevated, and that's what triggers the allergy. So we look at those levels and determine whether they're elevated or not.
So if you find that a specific allergy is elevated, do you treat that specific allergy as opposed to a general treatment?
You can. There are three ways to treat allergies. The first is prevention or avoidance. If you're allergic to, for example, to dogs and only dogs, and you don't have a dog, then one way to avoid suffering from those allergies is to avoid getting a dog, for example.
Getting the dog, right.
Or not, or if you go somewhere where there's a dog, making sure you're not petting the dog and then breathing it in or touching your face with it. Prevention or avoidance is very limited for patients who have allergies to dust, who have allergies to pollen and grasses and weeds, because they're exposed year round and there's no way to walk outside without getting that exposure. So that's very limited treatment. The second treatment is medication. Now, medication will not cure the allergies, but will oftentimes keep the patient from having the symptoms of allergies. So it can reduce or eliminate the sneezing and the itchy eyes and the watery nose. But again, that's something that has to be done on a daily basis in order to be effective.
Now, can these be over-the-counter medications, or do you generally suggest prescribed medications?
These are mostly over-the-counter. All these Flonase and Nasonex and Zyrtec, they used to be prescription medications, but they were deemed safe enough for the population to just determine if they want to use it or not, for patients to use it themselves. So most of these allergy medications are now over-the-counter. They don't require a doctor's prescription.
Although I would think it would be important to, rather than just say, I must have an allergy, I'm going to I've heard a commercial on TV or seen it, and I'm going to go ahead and try this particular. I would think that you would want to go to your otolaryngologist to determine what type of allergy you have before starting to buy these different medications.
Yeah, and oftentimes I'll see patients that have tried the medication but didn't have good success with it. And so they kind of waste a little bit of time treating a problem that they didn't really have, right? And taking a medication they didn't need. The other reason, and the third reason, and the most important one to see someone like me about your allergies is because there is a way to cure your allergies. Allergies can be cured with immunotherapy. Immunotherapy is also known as allergy shots or allergy drops. And the way they work is we provide your body with small amounts of the things you're allergic to. Over time, increase the exposure and get your body to stop reacting to the allergen. So eventually your body, after seeing this allergen for such a long period of time, it says, well, wait a second, what isn't this the same stuff we saw last time or last week? And the body eventually says, yeah, we saw this last week. Well, did it do anything to us? Well, not really. Well, do we keep having to react? Do we need to react to it constantly every time we see dust or pollen? So eventually the body learns not to react to it, and it can provide cure where you no longer have allergies.
I guess then the good news is there's actually a cure for allergies, which I was not aware of. I thought there was relief, but not necessarily a cure. Good news.
That is good news.
Well, how do you tell the difference between if someone has an allergy or they actually have a sinus infection? There is a difference there, correct?
There's a big difference. Now, some of the symptoms can overlap with each other. So the nasal congestion, the postnasal drainage, the watery eyes can come from both conditions. But when patients have an infection, oftentimes it will have yellow or greenish drainage out of their nose. They can have some facial pain and pressure along the cheeks, between the eyes, or in the forehead area. And generally, those patients feel ill. Not always, but they tend to feel ill, like they can't go to work or to school, particularly if it's an acute sinus infection. Allergies is more of an annoying symptomatic problem. They don't feel necessarily sick, but they're kind of stuffy and congested and sneezing a lot. Sinus infections don't typically cause patients to sneeze very much. But some patients can have both conditions. They can have a sinus infection and concurrently allergies. And oftentimes I look at both conditions when a patient comes to see me for that.
So if you're having a problem breathing, it's more likely that it might be a sinus infection. Am I correct?
Correct.
Okay. But in any case, see your otolaryngologist, so to speak. We get into the types of treatments, though, for sinus infections. That's a bit more complicated, isn't it?
For the most part, treatment for sinusitis is two types: medical therapy or surgical treatment. Now, within those, there are different types and different ways of doing that. But for the most part, patients who come in with acute or chronic sinusitis, the initial treatment is to put them on a course of antibiotics, concurrently with some oral steroids, which decrease swelling and inflammation. and having them on a nasal spray as well as some saltwater irrigations. That can oftentimes cure the infection. Some patients need more than one course of treatment to be able to cure the infection. But if that doesn't work, then we start talking about surgical treatments, or at least procedures that we do either in the office or in the operating room to open the doorways of the sinuses and be able to wash out and clean out the infection that's on the inside.
So is that where you get into your balloon sinuplasty or your endoscopic surgery?
That is correct.
So maybe you describe how that works.
Balloon sinuplasty is a procedure in which we use a small catheter that has a balloon, and we're able to get into the doorway through the doorway of the sinus and use the balloon to force the doorway open. That gives us access into the sinus to be able to irrigate and wash out the pus and the infection that's on the inside. The balloon causes the doorway to get stuck in the open position and therefore allows the sinus to drain much better. Traditional sinus surgery is where we go into the nasal cavity and the sinuses under anesthesia, and we use instruments to remove the doorway. So the doorway gets removed as well as a portion of the wall of the sinus to allow the sinus to drain much better. It gives us a little bit better access afterwards to be able to continue the irrigations for some patients. Now, some patients may not be candidates for the balloon procedure if they have nasal polyps. And nasal polyps can come from the infection itself or sometimes from allergies also. If patients have nasal polyps, then that would require traditional sinus surgery to remove those.
Is that like a septoplasty?
A septoplasty is straightening of the wall of the inside of the nose. A deviated septum, as it's called, can cause problems with nasal obstruction. And oftentimes patients who have both chronic nasal obstruction and recurrent sinusitis undergo surgery to fix both problems, not just their sinus issues, but also their breathing problems. So afterwards, they feel much better and they're able to breathe better than they did prior to the procedure.
So whether you're doing a balloon sinuplasty or an endoscopic procedure, I'm assuming it depends on the individual. That's how you decide what you're going to recommend?
That is correct. Some individuals are candidates for one or the other, or sometimes both. And then I have a discussion with the patient of what they feel they might be better for their lives in terms of the treatment.
So let's turn for a moment, if you don't mind, to another, shall we say, challenge for many people, because over 30 million Americans have hearing loss in both ears, which was a statistic that really amazed me, quite frankly. Of course, the good news is people today with mild or moderate hearing loss, as I understand it, can buy hearing aids at a store or online without a prescription. And the FDA estimates that's going to lower costs as much as $3,000 per pair. But I'm guessing before you say, well, I'm having a hearing problem and I can get something, without a prescription, and I heard this or saw this commercial, I'm going to jump to it. I suppose there again, they need to get some advice as to exactly what type of hearing, obstacles or loss they have. Am I correct?
Absolutely. That is a very true statement. And you want to think about hearing loss a little bit like your vision. If you weren't able to see well, there are options to just buy glasses over the counter at the supermarket or the pharmacies. But what is the reason for the vision loss? Before you treat that yourself, you'd want to see an eye doctor to make sure it's not macular degeneration or cataracts or something that needs a different type of treatment, similar with hearing loss. Hearing loss, again, can be of two different types. One is a conductive hearing loss, and the other one is called sensorineural hearing loss, also known as a nerve hearing loss. Conductive hearing loss comes from things like earwax impactions, fluid in the ear, infection in the ear, fungus that sometimes can grow in the ear canal. These patients will have hearing loss not because they need hearing aids or have a nerve hearing loss, but because they physically have something obstructing the sound. No different than putting an earplug in your ear. So you certainly wouldn't want to treat a conductive hearing loss with hearing aids. That would not be the solution. Seeing someone like me, an otolaryngologist, will allow examination of your ear canal and your middle ear to determine what type of hearing loss you have and whether it can be fixed right there in the office or a hearing aid is necessary.
So a hearing aid is not always the end result, the recommendation. There are other procedures, surgeries that you perform if the hearing loss is serious?
That's correct. And in fact, sometimes I've seen patients that will come in and say, Doc, I haven't been able to hear in my right ear for 6 months. And when I look at their ear, they have a piece of cotton from a Q-tip that has been stuck there all those months.
Oh my
And
goodness.
so I remove it, within 5 minutes in the office, and guess what? The patient says, "Oh, I can hear again."
All right.
So if you develop hearing loss like that, you don't want to delay. You want to see somebody like me. Now, there are certain medical conditions that can be fixed with surgery. If you have a hole in your eardrum causing hearing loss, that's fixed with surgery. Otosclerosis is a condition in which the bones of hearing become stiff, particularly the stapes, and there's a surgery that can fix the hearing loss. There's also nerve hearing loss, which is sensory neural. Now, that type of hearing loss comes typically from one of two things: either excessive or prolonged noise exposure, concerts when we're young, lawnmowers, factory work.
TV blasting at night when you're watching.
TV, listening to music too loud, which has been a problem with teenagers nowadays. And then the other cause of nerve hearing loss is genetics. So if you have a family history where as your family members get older, they start losing their hearing, then you're more likely to end up in that situation as we get older. And patients who have a nerve hearing loss are most of the time treated with hearing aids. If we make the sound a little bit louder, they're able to understand the words better and be able to hear the sounds better. Now, for patients that have severe to profound nerve hearing loss, there is a surgery called a cochlear implant, in which we implant a device into their inner ear that stimulates the cochlea directly and is able to allow them to hear much better. It's never perfect hearing like we have in our teenage years or in our 20s, but oftentimes it's improvement enough that patients can have a communication with family members and not have the frustration of not being able to communicate. Lack of hearing can be a significant cause for depression and isolation. Patients who can't hear well oftentimes are embarrassed when they have to tell others, "What did you say? Can you speak up?" Family members and friends oftentimes get irritated or frustrated with their loved one, even though they love them very much, but they get frustrated with them and oftentimes don't realize that they will lash out back at them. "You can't hear anything, I'm not going to talk to you anymore," or they quit. So it can be a significant problem with society and socially for a lot of these patients.
So I think what it really boils down to, the thing that worries me, is you're starting to see so many commercials recommending hearing aids that you can get without prescriptions, and consumers jump at that thinking that's the solution. I think what you've described is underlying the seriousness that you really need to talk to your physician, your otolaryngologist, to determine exactly what your problem might be. So I'm glad you've explained that. I think that's very important for our listeners and for their family members. Now, getting to one last subject. You're a highly experienced ear, nose, and throat specialist, and there have been many advances in your field, which obviously you're on top of. But the thing that amazes me is after all these years, there's still no cure for the common cold, coughs, sore throats. Any hope coming down the pike?
There is some hope. And the problem with the common cold, the common cold, for example, comes from a viral infection. And that's usually rhinovirus or coronavirus, which obviously has made a huge impact in our world in the last few years. But the difficulty in curing these common colds and these viruses is that they mutate, they change over time. And those changes are very difficult to predict. And some of these mutations and changes will cause a virus to be more problematic in terms of causing an infection than others. So if we look back in history over the year, influenza, which comes from, or the flu, which comes from the influenza virus, is something that has been around for, 100 years or more, however long it's been. And we have something to try to mitigate the problem, which is the flu vaccine. But the flu vaccine is very effective some years and not as effective in others. because in order to create a flu vaccine, the researchers and the people involved are trying to make an educated guess as to how the influenza virus is going to mutate before the flu season starts.
Because there are so many different variations. Every year there's a new variation.
So many different variations. So the one good news we have is that the explosion in genetics, the understanding of genetics, medications that are being used through the advances of genetics may at some point in time allow us to be able to either reduce these significantly where they don't cause as much of an impact, or potentially even cure them. But as of yet, we don't have a well-known cure for any of these viral infections.
Well, and that's again the sad news. But I suppose now, what do you recommend? I'm sure that patients don't want to bother you if they have a cold or a sore throat or whatever, so they go to their pharmacy or they go to Walgreens or CVS and they pick up something over the counter. Do you have any recommendations for people who suffer these types of cold symptoms? How can they make an educated choice? I suppose that's my question. So
the majority of patients that start off with an upper respiratory infection, most of the time it is a viral infection, okay? And what I tell some of my patients who have these recurrent problems, if they're suffering from the symptoms for a week and they're not getting better, then they should clearly call my office so I can figure out why. The majority of flu infections or common colds are going to last about a week in terms of the majority of the symptoms. Typically, by the end of 7 days, patients are already starting to feel better. So because there is no treatment or cure for these viral infections, over-the-counter medications to help with the symptoms is what's indicated. But clearly, if they're not getting better or they're getting worse a week later, then they should definitely call my office to see me, or their ENT doctor, their otolaryngologist.
Well, I think we've unfortunately just about run out of time, but if I'm correct, we've covered most of the gamut of what you do as an otolaryngologist. I want to thank you, Dr. Riefkohl, because the information you've shared, I mean, some of it is, and I thought I knew a bit about it, but some of it is new to me. So I know that my listeners are going to appreciate exactly what you've conveyed, and I want to thank you so much for your time. I know you're very busy. I know that you're backed up as a very, very busy doctor, so it's really appreciated that you took this time with us.
It's my pleasure. Thank you for inviting me to come and talk about these topics, because they are important, and providing patients with the right, accurate information seems difficult these days with Google and everything else that you can research. But getting your information from a trusted source is what's going to be best.
And so I think that's the most important part of the message. So in any case, thank you again, Dr. Riefkohl.
Thank you.
To our listeners, I'll be back in a few moments with another health and wellness tip. Stay tuned.
Live Healthy Longer is sponsored by the LHL Institute, where aging presents a new stage for opportunity. And the longer we live, the more beautiful life becomes. Our website, jamespolakof.com, contains important links to ear, nose, and throat conditions, including sleep apnea. Our site also has a great selection of informative podcasts and health-oriented blogs by Dr. Polakof. Again, please visit jamespolakof.com. That's James, Polakof.com. Now back to Dr. Jim Polakof.
Since we've been examining respiratory conditions, one of my concerns is how few Americans are taking advantage of the RSV vaccine, particularly older adults. Almost 160,000 older adults in the U.S. will go to the hospital, and 6,000 to 10,000 will die from RSV this year. 2024 will see RSV rising, so please get vaccinated as soon as possible. Come to our website, jamespolakof.com, for more information about RSV. And please tune in to a new podcast episode each week. This is Dr. Jim Polakof. Thank you for listening. And remember the words of Voltaire: I have chosen to be happy because it is good for my health.